As of this morning, we are in daily contact with 141 people who have tested positive for COVID-19. We've received criticism for not providing real-time data, but that is just not feasible given how quickly the situation changes. It takes time to collect, verify, and then report accurate information. We update our community every morning at 9 a.m. with what we know at that time. We only want to provide the community with timely, relevant, and accurate information. Today, Medical Officer of Health, Dr. Wajid Ahmed, will be providing projections. Please don't lose sight that these numbers represent the people in our community, our families, our friends, and the people we care about. I will now share our daily updates. We now have 11,283 confirmed cases of COVID-19 in Canada and 2,793 cases in Ontario. Chatham-Kent has 9 cases, and Sarnia-Lambton has reported 59 cases. Michigan now has 10,791 cases with 2,858 cases in Detroit. As I said, we have 141 confirmed cases of COVID-19 in Windsor-Essex, an increase of 13 cases since yesterday. 29% of our cases are between 50 and 59 years of age. 46% are male, 54% are female. We have 3 COVID-19 outbreaks in long-term care facilities. I'm extremely and very sad to report that 2 residents have passed away in 1 long-term care home due to this outbreak. The health unit continues to follow up directly with everyone who has tested positive and negative for COVID-19. Those that are waiting results are to remain in self-isolation. If you have tested negative for COVID-19, you must remain in self-isolation for the remainder of the 14 days. Overall, 1,334 individuals have been tested for COVID-19, and there are 218 tests pending. Testing for COVID-19 should be based on clinical assessment. Where there are shortages of testing kits, then the following groups will be prioritized: symptomatic healthcare workers and staff who work in healthcare facilities, symptomatic residents and staff in long-term care homes, hospitalized patients admitted with respiratory symptoms, members of remote, isolated, rural, and Indigenous communities, and symptomatic travelers identified at a point of entry to Canada. I will now turn it over to Dr. Wajid Ahmed, our Medical Officer of Health, for further updates regarding COVID-19.
My team and I would like to express our condolences to the family and wish them peace and privacy during this difficult time. As Teresa mentioned, that these are tragic losses in our community. These are people we are talking about. These are parents. These are grandparents. It is our responsibility to protect them. It is our responsibility to make sure that we are doing everything that we can to prevent from these type of deaths happening in our community. I'll now move on to the details that we promised to share with all of you, our epidemiological summary of all the COVID-19 cases in our community, and building up on what we reported with these additional deaths in our community and what it could look like if we are not acting on it right now. The epidemic curve, or epi curve, it basically helps us assess the progression, help us assess to see progression of the disease, whether we are talking about it in the community or in any outbreak situation. We created this particular epi curve to show when our confirmed cases started showing their symptoms. Most of our cases started showing their symptoms in the last 2 weeks, which is pretty evident in what we are looking in the slide right now, and the journey continues, and we should be providing more evidence as we collect information on the additional cases that we received today. This next slide is to show we are using data to give us an indication of what does age and gender have an effect on these cases. The purpose of creating this graph is to show if there is a gender difference in getting those who are infected right now. Between male and female, it is fairly split between male and female, and so there is not really a big difference with respect to gender. when we are looking at the age distribution to identify if there's any particular age group that is affected more than the others. And if you do the maths, almost half of these cases were between the ages of 40 and 59, with the highest group that is impacted is between the ages of 50 and 59 years. We use exposure history to identify potential mechanism of spread of any disease. We already knew that COVID-19 is a new novel coronavirus and it did not exist here. So it has to be brought in from outside. The data that we are looking at right now, it shows more than half of the cases were due to travel. Close to 20% of these cases were a contact of a confirmed case. That is why we talk about self-isolation, even with your family members, and to avoid infecting them. At least 1/4 of these cases, or close to 28% of these cases, did not report any travel history or do not recall coming in close contact with a COVID-19 case, and we can assume that the cases are acquired in the community, hence the term community transmission we are using. We heard some of our residents raising concerns that we are only testing who travel, but we see clearly that we are testing those individuals who did not travel. But those testing were done based on the clinical assessment. It is very important to note that not everyone needs to be tested, but there will be some who will get tested based on the clinical assessment. Looking further into the exposure, we wanted to see how many of these cases are a healthcare worker or visited a healthcare facility. From the data, we can see a little over 40% of these cases reported being a healthcare worker. Almost 10% of these cases reported being healthcare facility prior to becoming ill. Being a border city, we understand that our residents cross the border more frequently than others. Also knowing that number of cases across the border is very different than what we have in our community. We further analyzed the data and breaking it down into international travel, that is people who travel outside of USA and Canada, people who traveled only to Michigan, and people who traveled to US other than Michigan. No surprises there. Among those who travel, a little over 60% of them traveled to Michigan. Next, we wanted to know what kind of treatment was needed on these cases. Just like we expected, a little over 80% are recovering in their home with mild symptoms. Roughly 15% of them hospitalized, and around 4% of them are in ICU. Now, the big question, what we were asking is, where are we heading? This graph shows the number of cases each day and its trajectory. If we continue to go at the current rate, by the second and third week of April, our case count could be in thousands. Not everything is as bad as it sounds. We understand that we had a huge backlog and it's currently cleaning up, but it should be concerning for all of us that right now the cases are doubling fast and we must do everything to slow it down. Now we will talk about these projections made from a purely research perspective and how these public health measures will help us get through this pandemic. A disclaimer for this model is these are not absolute and it can change due to any factor. These are only projections. The model uses the techniques put forward by University of Toronto and University of Guelph. Our model also looks at the duration of our social distancing measures over a 4, 12, 26, 52, and 72-day period. This allows us to understand the impact of our social distancing measure and what threshold works best to reduce the spread of COVID-19 in Windsor-Essex. Now let's talk about the numbers. On your left-hand column, it shows base case, meaning that there are no measures in place, and if we look closely, our new case counts will increase every day, and we will see a peak 4,000 cases in one day by day 100, in approximately 3 months. The cumulative case count for entire duration will be in excess of 200,000 cases in our community. The model assumes that nobody is reinfected with COVID-19. On your right hand, it It shows the physical distancing measures implemented by everyone and the number of days these measures are in place. When we are putting these measures for only 4 days, we will flatten the curve only a little bit and delay the onset of these cases only a little bit. If we increase the duration of these measures for 12 days, we make some progress by delaying the peak, allowing the time for the healthcare system to be ready. But the real difference we start to see when we have these measures put in place for more than a month, and real flattening effect after at least 2 to 3 months of strict physical distancing. Let me reiterate. The model assumes that everyone is strictly following the physical distancing measures, but we know in reality that doesn't happen. We can see the impact, why it is important for everyone to follow it. When everyone is following it, we will flatten the curve immediately, and all of this will be over soon. This is in everyone's best interest to flatten the curve as soon as we can. Moving on to the burden of COVID-19 in our hospital, more specifically on ICU beds. According to Windsor Regional Hospital, they currently have 83 beds, and the model showed this black line identifying the capacity at ICU. Nothing different on the left-hand side. It uses the same scenario when there are no measures in place. However, on the right-hand side, it shows the impact of physical distancing to delay the peak, flatten the curve, and after approximately 2 months of strict physical distancing measures, we can flatten the curve to let our ICU, our healthcare system, cope up with the demands. This is important because we do not have enough ICU beds or do not have enough healthcare workers who are trained to work in ICU. Many of these cases will die, and nobody should make that choice. Now, this is the most scary slide for me. On the left-hand side, you will see the number of cumulative deaths in our community. We can expect to see at least 4,000 deaths by day 200 in our community. On the right-hand side, we can see the impact of physical distancing in preventing these deaths. Again, this assumption is based on the fact that everyone is following the physical distancing measure for at least 2 months or longer. We can really flatten the curve. This is the final summary slide based on all the models that I've presented. Graph on the left-hand side shows the total case. We can expect to see more than 200,000 cases in our community if no action is taken. But if strict physical distancing measures are in place, it will reduce that number by 95%. Bottom left-hand side, cases requiring hospitalization. We can see more than 20,000 admissions in our community if action is taken. But if physical distancing measures are in place, it will reduce the number by 96%. Graph on the top right-hand side, cases with mild moderate infection, more than 60,000 cases, but with strict physical distancing, we can see a 95% reduction in these cases. And also from the number of deaths, more than 4,000 deaths if we do not do anything, and we can bring it down and to change that number by 96% if strict physical distancing measures are in place. These numbers give us a sobering thought. What is at stake and why every levels of government, every public health department, the entire healthcare system is concerned about. We all have a responsibility to our friends, family, neighbors, and community to practice physical distancing so that we can save lives. We can flatten the curve. We give an opportunity to our healthcare system to address the growing epidemic of COVID-19. We have to keep in mind that some of these physical distancing measures, like school closures, were in place prior to our first case. So we have a head start, and let's use that to our advantage. We are learning from many jurisdictions. Let's use this to our advantage and continue to practice social distancing to help everyone in our community.
Okay, we'll start with CTV.
I guess the first obvious question is, what can you tell us about the 2 deaths today?
So these 2 deaths in the long-term care facilities are elderly people, and one man in his 80s and woman in her 80s. They passed away yesterday due to complications from COVID-19.
Can you tell us what facilities they were in?
We like to respect the privacy of these individuals, and as Teresa mentioned, these are people. We should be respecting them. For some, it's just a number, but for family, it's real people, so we should respect those privacy.
Yes, I'm processing all of those numbers. I guess I'm wondering if there's any indication that as a community, we're already doing a certain amount to flatten the curve. Is there anything that you can say about that? If the measures that we have in place so far are working, or if it's just too soon to tell?
I would say it's too soon to tell. We have these measures in place. We are seeing some these cases that are coming in. Some of them are a result of a backlog that was there. But in the next week, we expect to have more data to suggest what these numbers are heading.
And I do just want to ask one more question about the 2 deaths in the long-term care home. I know you said which home that's in, but now that we've had 2 deaths, are you able to say the new numbers of the total numbers, how many are residents in long-term care homes of the positive cases?
I have to break it down, but there are a number of people who are in long-term care homes, and so in one of the home we have 5 cases. The other home we have so far 1 case only, and the third home we also have 1 case only. So if we do the maths, it comes out to be 12 cases in total in the long-term care homes and retirement homes.
12 cases in total, and is that just residents, or does that include staff members?
That includes a staff member as well.
And mention that 96% reduction. Are we close to that level?
Again, it's too early to say anything at this point that how effective these measures are, but we know this model, when we're talking about a 96% reduction, is based on strict physical distancing, when everyone is following strict physical distancing. In reality, that doesn't happen that much, so the truth lies somewhere close to that, and but it would be too early to say at this point that how much of a change that we will make. I like that we go all the way down to 96%, but this is yet to be seen right now.
So they were both waiting for results. So in the long-term care homes right now, I'm not sure if you can get into this, how many residents are still waiting for results?
There are a few who are waiting for results, but there are protocols in place in terms of how we make that determination. Once it's out there, the likelihood of other residents having COVID is high. Based on our protocol, we test up to 4 individuals if they are symptomatic. But then recognizing that if they are close contacts, the likelihood of someone who is in close contact of individuals would be very high, and we are still waiting for some of the results from these residents at this moment, and others we are also monitoring long-term care homes as well.
Thank you.
Any questions from Blackburn?
Yeah, based on your modeling, when you're looking at the pay frequency that you're talking to your place for us to see a complete cutting of the curve, is that based on, if I come to the point of our first case, because we got out ahead of this, could we see a shorter time frame, or do you think this we're looking at the 2 months for these measures?
So I think this is still too early to determine what it means, and I think we will just have to wait and see how these measures will come into play. As I mentioned, that we had a head start. We had our school closures and some of those measures put in place ahead of many other cases, but we also have to factor in our cases and our proximity to to Michigan and our travel to Michigan. So it's, again, these are all based on assumptions, but it still is too early to say what it looks like as we move forward.